My presentation is based on a paper titled "Does Cannabis Use Affect Treatment Outcome in Bipolar Disorder?" So the authors start off with an association between development of schizophrenia and cannabis use. To my knowledge, it's got something to do with the lower age of onset in schizophrenic patients when they use cannabis. So the equivalent research has not been carried out in mood disorders, especially bipolar disorder, as pointed out by the authors here. They also point out how there's cannabis use observed in bipolar disorder patients. Symptoms associated with both bipolar disorder and cannabis use may complicate and worsen one another, and how there's potentially some use in knowing about these associations in terms of treatment strategies. So they hypothesize that both clinical and social outcomes are worse social and clinical outcomes are associated with cannabis use. They go over the participants here, and they're from a separate 2-year observational study that was looking at pharmacological treatment outcomes of mania, and those patients were all 18 years and above. They were taking antipsychotics, anticonvulsants, and/or lithium, but not antidepressants or anxiolytics. And here they checked through self-report and clinical judgment at baseline, 12 weeks, 6 months, and 1 year on a 4-point scale, like how much cannabis they were using, the participants were using. So the baseline time point was actually 3 months before recruitment for the observational study, before that started. So they formulated 2 groups, cannabis users and non-cannabis users here. So clinical treatment outcomes were measured by self-report questionnaires for general symptoms, mania, first-order psychotic symptoms such as hallucination and delusions, and depression. And they also measured medication compliance by investigator assessment. For social treatment outcomes, they looked at whether the participants were living independently, occupational function work-wise, relationship status, frequency of social activities, life satisfaction, and dependence, or the number of dependents who were reliant on the participant. So multiple regression analyses were conducted and potential mitigating variables were checked. Here, alcohol abuse, age of onset, and the current age were of interest, and they're going to be of interest moving forward into this presentation. So cannabis users were seen to have significantly greater scores for overall bipolar disorder symptoms, mania, hallucinations and delusions, and also higher alcohol use, abuse, and dependence, along with other substances. However, they did not find any correlation between cannabis use and depression measures. And cannabis users had significant associations with reduced likelihood of being in a relationship. They had higher engagement in social activities, but that was mediated by age of onset, and alcohol abuse. And they also had correlations with lower life satisfaction. That was mediated by other substance use as well. So correlation between cannabis use and independent living, number of dependents relying on the participant, and occupational impairment did not reach significance. So the authors go over more details about other findings about cannabis use and higher association with mania severity, onset, duration of episodes, and delayed abatement. So they also go over genetic influences, talking about psychosis increasing, influences of cannabis, and the probability of a start of use. They also try to explain the lack of associated depression symptoms due to mania, or the participants being recruited at a manic phase. They also go over social outcomes and how that may be explained by alcohol imbibement sessions with peers and their younger age. So the paper does a decent job of providing details into cannabis use and bipolar disorder associations, and may also provide insight into or routes of insight into common elements present in both schizophrenia and bipolar disorder. However, the paper did not account for personality. Extroversion could perhaps have explained some of the social outcomes if it was checked. Same with neuroticism. Higher or lower neuroticism could influence how prone the participants were to depression. They also did not check levels of physical activity and socioeconomic status, and those could have also had some effect on how resilient the participants were. And also, they did not look at clinical judgment or the criteria for it. They did not specify anything much about it. So that is it for my presentation. Thank you for listening.